I'm a believer in specialization. I think the more people see something like Apple B, you get to know it better. So as we remain in the perineum, he can continue with Apple B, so specialization is a strong aspect in which the Aga Khan University have done. And Gunga talked of patients being few. As a doctor, you want more patients. I think we need to go beyond that. What we need to think about is if you are the patient. Yeah? If you are the patient. You see, you have been seeing many patients, and then all of a sudden, you are the patient. You want to get the highest quality of care. And therefore, you must support people who are actually striving to achieve the highest possible care. And therefore, we now rope in the policy. Kenya Medical Association is in the policy space. We represent health workers, I would say, because you can't have everyone in those bodies. And we start with shisha. Does shisha pay for Apple B? You get my point. We would want to drive policy to a place where before you reach Matolo at Old Mutual, is the government of Kenya actually facilitating us to get the highest quality of healthcare by paying for it? Because what kills people is not the lipids, it's the inability to get treatment for the lipids. And therefore we must actually push to have the government actually be the one to actually pay. The ideal situation would be that you walk into Ngunga's clinic and shisha pays, and therefore Kenya Medical Association is actually a board member of the Social Health Authority. As we don't waste time, we say, which new body are you forming? We want to be in that board so that you are able to provide direct input into that. So some of the policy directions that we need to go to is to have a push to have more resources pumped by Treasury into healthcare so that we are even able. So the Kenya Cardiac, I hope you listed Apple B as one of the things that is listed as gazetted to be paid for. Otherwise, what pushes people into financial distress is the inability to pay for it. Services Ngunga is there waiting, but the guy cannot access. The other issue is that Kenya Medical Association also has representation at the Kenya Medical Practitioners and Dentist Council. What is the import of that? The import of that is quality. We in this country for a long time have been having issues with what is called scope of practice. There are people everywhere purporting to be able to treat anything. So the KMPDC, in continuing to strengthen that, should actually be identifying your scope of practice. And with the time, we've come from the ages where there was one doctor with 100. We are now having more doctors and people. So if you find Kigondu trying to, treat Apple B, I think it should be put in, I have no business treating Apple B. But because of the economic issues facing everyone, is trying to treat what they can't. And I think Dr. Matolo will agree that this actually increases the cost of care. So we are having a push by government to try to get lower level people, so to speak, going beyond their scope, saying it is cheap to treat people. Doctors are being replaced by, nurses are replaced by other cadres because of cheapness. But cheap is expensive.
When it comes to an occasion like this, we are looking at cardiovascular disease, and we've learned over time that the burden, morbidity and mortality from cardiovascular disease is continuously rising, not just globally. We read a lot of data from the West and so on, but of late we've tended to collect our own data, look at it, look at trends, and be able to devise ways, modalities, strategies to combat the rise of cardiovascular disease. In Kenya, we've had numerous surveys to look at the burden of cardiovascular disease. Just to quote a few, we normally conduct the May Measurement Month screening every year between the month of May and September to look at the burden of hypertension and related comorbidities. We have identified about 7 healthcare institutions across the country, including Aga Khan University Hospital, and these are facilities that will be helping us to carry out this research project to look at what are the unique characteristics and risk factors for patients who are getting premature acute coronary syndrome. And I'm happy that this is happening at a very opportune moment when we are launching the lipid clinic. So one of the key things, of course, we'll be looking at in these patients is their lipid profile, and we even go a step further to look at the finer aspects of the lipid. We'll be doing the screening for lipoprotein little a, ApoBs, and so on. And these are not readily available across the country. So I guess what will be happening if some institution in one of the counties has this unique patient who has markedly elevated lipid levels and they're not able to tell what's going on, we'll quickly refer that patient to Dr. Ngunga's clinic, and you'll be able to run some of those tests and be able to tell us, are we dealing with genetic disorders of lipids, or what exactly we're dealing with.
And this event is very timely. I was reading Kenya Demographic Survey report of last year. Africa was known for the infectious disease, the TB, the HIV, the malarias of this world, but surprisingly or shockingly, 4 out of 10 deaths, 40% of the deaths in the country are happening because of the NCDs. I think the disease burden of cancer and the diabetes and the hypertension is increasing. Hence, I think this clinic and this project is extremely important, and obviously we should invest in more resources, be it people, be it equipment, be it testing, and partners with companies like Novartis and others, so that we will probably not be able to reduce the burden, but at least we can catch it early and treat it. And research has shown that when such diseases are caught early, the outcomes are better, and obviously the costs are lower as well. Rather than wheeling the patients into cath lab or OR, you treat them in the clinics. So obviously the costs are lower as well.
It is true, lipid disorders will continue to increase, and we can work in collaboration with our colleagues. We're not doing this alone. We are looking with diabetologists, other physicians to treat cholesterol disorders. I will tell you about our model, which is what we put forward, because we said when I met groups, they were like, oh, are you now going to be seeing these patients all the time? What do you do? No, we actually have a referral system. So what do? You have a patient who you are treating post-MI or with diabetes, but the cholesterol is not coming down. I don't know why. These are the patients we see, and we evaluate the drugs, we see what the problem could be. We analyze everything, and we actually tell you this is how you should treat these patients. And they've come here, and actually when you put them on good treatment, you find the LDL less than 2. On primary prevention, they could not take any particular drug. We change their medicine, we give them a new alternative, and the LDL comes to the target. If the patient has family history of MIs, we tell them this is what needs to be done, because sometimes the patients are not sure. So they want just a very clear path. So we are not duplicating. We are actually just offering advice, and this patient can go back to their doctors because they have many comorbidities. Some have diabetes, some have hypertension, they have heart problems. So it is true, they go back to their physicians with now a well-treated cholesterol and with a clear plan of action.